Hello and welcome to another episode of Local Expert Interviews. My name is Michael Grady, and today we're going to be speaking to Dr. Gary Alder of River Forest Dental in Chicago, Illinois. For more than 30 years, Dr. Alder has been dedicated to providing quality dental care to those searching for general, family, implant, and cosmetic dentistry procedures. Welcome, Dr. Alder.
Thanks, Mike. It's good to be back with you.
Dr. Alder, please tell our viewers a little bit about yourself and your practice in Chicago.
Well, I've not recently, but 2 years ago, we relocated from Rush University Medical Center here to River Forest, and my official name of my practice is Global Facial Aesthetics, because that's what we concentrate on. But from my Rush days, I'm still doing a lot of work with sleep apnea and people that are suffering from sleep disorders.
Well, today I'd like to talk to you about the development of sleep apnea services in the dental practice today.
Yes, it's a very interesting field. I first became involved with it many years ago when Dr. Rosalind Cartwright and Dr. Charles Samuelson invited me to participate in some research they were doing. Now, we selected 40 patients, and my role in it was mainly to take cephalometric x-rays and analyze them, as well as make the prostheses and adjust the prostheses for each of these people and to interpret the results with them.
Well, let me take this back to the beginning for our viewers that might not know what sleep apnea is. So could you tell our viewers very simply, what exactly is sleep apnea?
Yes, that's a problem for many people that goes unrecognized because it happens when we're asleep. Apnea implies that the patient stops breathing for an amount of time that is not normal. And during that time, in order to qualify as apnea, the oxygen level in the blood needs to fall significantly so that the brain kicks in another mechanism to make us breathe again. So the apnea, if you were to hold your breath for 30 seconds or a minute or more, and sometimes it's more than a minute, that our oxygen levels would, of course, decrease. And as we know, sleep is like a third of our life, so it's an important time of our life.
Well, can you talk to us a little bit about your journey in investigating and, of course, treating sleep apnea?
Yes, as I mentioned, started working with Dr. Cartwright and Dr. Samuelson with these first 40 patients, and we found that it wasn't just the facial structure, although some people with rather retrusive mandible were more likely than not to contract sleep apnea, more likely than the average person, let's say. But other factors, particularly being overweight or having a very thick neck, kind of like me, short, thick neck, made you more susceptible to this disease.
You spoke briefly about doing research into sleep apnea. Can you talk through a little bit about what was your role in the research?
Well, my role initially was to make the appliances for the patients. We take impressions and so forth and actually build them in our lab, and then do cephalometric x-rays. So we would measure the size of their head and compare that to standard norms. And what we found is that people with bigger heads and narrower airways, in those dimensions, were more likely than not to be in the group that had sleep apnea.
Dr. Alder, you've mentioned cephalograms. Is that what you mentioned?
Yes, a cephalogram is an X-ray. It's usually a lateral X-ray of the head, and that's the most common one we would use, although we did both dimensions, anterior, posterior, and laterally, so we could compare the size of the airway. And although, bigger people you would think have bigger airways, when that doesn't happen, bigger people with smaller airways tend to end up to be on the apnea side rather than bigger people with bigger airways. So it's all a matter of proportion.
So tell me, what exactly does a cephalogram show?
The cephalogram, the specific areas that we were looking for would be narrowing of the trachea, the passage of the air through the mouth, through the nose, and into the lungs. So we would look in that area because that's where the obstruction usually would occur.
So sleep apnea is really a restriction of airflow when you're sleeping, correct?
Well, obstructive sleep apnea is, there's different types of sleep apnea. Some are central, like in the brain, but the ones that we can treat with the dental appliance and with some types of surgery, those fall in the category of obstructive sleep apneas. And usually what the obstruction is the tongue rolling back in the throat and causing the airway to collapse. And you know, I don't want to get too scientific here, but the Bernoulli principle, such that if you have air passing over an object, you know, briskly, it can close the airway down, and that's what happens as the air passes briskly over the tongue, and that it will even have a tendency to close that airway down even more.
Well, let me ask you then, what other conditions accompany sleep apnea?
Well, obesity is one of the most common factors. So we look at a patient's BMI and see what their condition is, and if although that's not the only factor, but if a patient is overweight and were to be able to lose weight, then their sleep apnea would likely to respond as well and become less severe and sometimes even go away.
I think a lot of people equate snoring with sleep apnea. Are they together?
Snoring is not sleep apnea. It's a kind of a precursor, though, and people who snore are demonstrating narrowing of the airway, and those structures through the snoring process become irritated and inflamed, and will start the patient on the path to becoming apneic.
So tell us, how do dentists help people that have sleep apnea?
Well, what we found is the initial appliance did a few things. It would bring the jaw forward and open the bite. The initial appliance was also would grip onto the tongue and pull the tongue forward. And it was very effective. However, it was not very patient-friendly. Patients didn't like having their tongue held in a suction cup. And so some of the more modern devices came about, and they are equally effective in bringing the tongue forward and opening the bite. And basically, if you can open the airway, that's what really counts. It's not so much whether your tongue's forward or your bite's forward, but if the airway opens by moving the mandible forward, then we can be effective at relieving the sleep apnea.
Well, can you talk to our viewers about what devices are popular now with your patients?
Well, there's several on the market, and they all have a few things in common. But basically, what they do, as I mentioned, is opening the airway by moving the mandible forward and opening the bite, moving the chin forward, further away from the nose, and moving the mandible more forward. All of the preferred devices have a mechanism where we can adjust how far the mandible comes forward or moving it backwards. Initially, I have to make a determination of what I think the patient can tolerate, because many people say we start them out at, say, 4 millimeters of mandibular movement to anteriorly. After they've worn the device for a few weeks, oftentimes we can crank that up to maybe 4 to 6 more millimeters. So it's advantageous to open it and then open it a little more. Sometimes I may overguess and I have to move it back a little bit, especially in the beginning when the patients are just learning how to tolerate the appliance, and then we can gradually move it forward later on. Some other things that help us a lot, we now have computers that can gauge how much the airway is open and how much the oxygenation is playing a role there. So we can titrate this for each individual patient.
So what exactly is the computer measuring then?
Well, initially, all patients undergo a polysomnogram, which measures 16 parameters, brainwave as well as the oxygen level and how much we're moving, what our body position is. Sometimes sleep apnea is people only snore and have apnea episodes when they're on their back. And if they can sleep on their side or side to side, then it's very minimal, and we can control it with just say a tennis ball in the pajamas or something like that, or placing a pillow so the patient doesn't roll onto their back and they sleep on their side. Sometimes simple things like that can solve the problem. They can get a good night's sleep without getting even into a dental appliance. But we can diagnose that through the polysomnogram, which is done in the sleep center. But it's not practical for us to titrate our oral appliances by sending the patient back to a relatively expensive sleep center all the time. And I like to use a company called MediByte. I don't know if you can see this on.
If you can hold it up a little higher, there you go. Yeah.
There we go. Bring it a little closer to the camera. MediByte is one of the early companies that investigated this, and they have some of the finest computers around. As you can see, this is like even smaller than a deck of cards, and the patient can wear this at night at home, and we can find out how they're sleeping with their appliance in their own home and determine what we can do to make their experience better. What I really look forward to is that patients not only can sleep well, but rest well and wake up with more energy, feeling rested, and some of these problems of snoring and irritating the airway will dissipate. Patients have more energy, they can exercise and be more active during the day. They don't suffer from excessive daytime sleepiness. So they can, again, go on a program of better nutrition and better exercise. And usually they are on the heavy side, and they can lose some of that weight. Otherwise, it becomes a vicious cycle. You don't sleep well, you don't eat well, you're tired, can't exercise. It becomes a vicious cycle, and you put on more weight. As a result, your apnea becomes worse and worse.
Well, clearly the patient initially comes to see you in your office, and then you mentioned that they can actually be measured in a sleep center, but then you also measure, you talked a little bit about some of the things that are home environment issues. So do you actually go to the patient's home to talk about some of these remedies?
No, I usually don't need to go to the home, but we do send them there with our computer, and it gives us the kind of data that we need. Otherwise, it wouldn't be very practical. And they've already had the observed sleep study. All patients who receive these type of appliances are by prescription only, and the physician has to evaluate them and determine that they indeed do have a problem, number one. Most patients know if they snore, or their spouse knows if they snore or stop breathing during the night, but there's a matter of degree. Some people can be anywhere from mild to moderate to pretty severe. The more severe patients, we tend to put them on CPAP, which is, CPAP stands for continuous positive airway pressure, and it's a device that fits over the nose and sometimes the mouth even. And when the patient needs to breathe, if their oxygen in their blood falls, the machine will give them a breath automatically, or if they're getting ready to take a breath, it'll assist that. So they become very sophisticated. The trouble is they're hard to travel with. You have to take along another suitcase, and they're hard to, if you're the other person trying to sleep in the room, that's difficult as well. And some patients just plain don't tolerate it. So, and then there's some patients who need all of the above. They need CPAP, they need the dental appliance, and they need their bed raised and things like this. So yeah, it's kind of a team effort, but for the most part, we're very successful with the mild to moderate patients who don't have the severe cases to start with. But sometimes I'm making appliances for people who are severe and who are not getting along well with their CPAP, and in combination with the CPAP and the dental appliance, they can tolerate the CPAP better and get back on the way to health.
So for people that might not interact well with the CPAP, are there any other treatments for the disease?
Well, there are, and the surgeons have been very good. Usually ear, nose, and throat people are able to do modifications of the airway, either through shortening the palate. There's actually there's over a dozen surgical methods that are employed in sleep apnea, and all of them have some degree of success, and some of them are used in combinations, and they all help to a certain degree, but surgery is generally not the first route we like to take, even for the severe cases.
Thank you, Dr. Alder. You have provided our viewers with a great deal of information about sleep apnea and how dentists can actually help their patients. I'd like to thank you for sharing with our viewers.
Always happy to help out, Mike. It's good to see you again. Thanks for the interview.
Thank you, sir. Again, my name is Michael Grady. This has been another episode of Local Expert Interviews. We've been speaking to Dr. Gary Alder in Chicago, Illinois. If any of our viewers would like to get more information from Dr. Alder about general dentistry or sleep apnea, please refer to the phone number at the end of the interview. Dr. Alder, thank you again so very much.
Great. Thanks. Have a good afternoon.